Dr. Martin, when do you think is the best time to do a PET scan? Interim PET scan, I'm talking, not post-treatment.
Yeah, so it's a good question, and I think a lot of different institutions have done it differently over time. The standard at Cornell, and I would bet most institutions now, is after cycle 2. There was recently a study that we will see presented that tried to come up with a more evidence-based answer to this question, where a group of radiologists looked at a database of PET scans that were done after cycles 1, 2, 3, or 4, and found effectively that the best time to catch patients with the best response was a PET scan after cycle 2. So those PET scans had a very high negative predictive value. And the best
regardless of the presentation, obviously.
Right. The best time to look at a patient who is likely to do poorly was a PET scan done after cycle 4. Yeah. In practice, that's intuitive. I think that many of us are doing PET scans after cycle 2, and we feel good about ourselves when it looks good. If it looks a little bit less good, but still appears to be on the right track, often I will give another couple cycles and repeat the PET scan, and if that's positive, then I'm a little bit more discouraged or am more likely to change therapy. And I think that practice is probably pretty common and is supported by now a large database.
I think for audience, it might be interesting to mention the fact that sometimes the gray zone PET scan interpretation, it's better with a Dobel score now, but still have some issues sometimes, particularly interim PET scan, and then the delta SUV, drop of 60-70% really has an impact. So it's something that is helpful. But I think I want to switch to Nathan and say, the PET scan is always has a lot of questions. No question, achieving a negative PET scan post-treatment is good. But I think there's something that might be promising in the future is cell-free DNA. Looking at cell-free DNA to quantify, quote-unquote, the response, and combination of PET scan and cell-free DNA is extremely powerful in some studies. You want to comment?
Yeah, so this is the big issue, is being able to figure out, and I think this is kind of what we touched on with the IPI, as long with PET scans, it's at least been very difficult to, not only figure out who is going to do poorly following induction therapy, but then trying to figure out when patients will relapse. And what we've done in the past is do IPIs and PET scans, and then do serial PET scans for a certain amount of time, and then move to kind of long-term surveillance. But this is all somewhat, there's not a lot of evidence that there's any reason to do it this way versus some other way. In other words, the scheduling for imaging is really based upon the patient's risk for relapse. So I think the holy grail would be to develop some way that we could actually measure the disease at a molecular level and predict patients' relapse before it happens clinically. And this is kind of the hope of determining or following patients' cell-free DNA. There have been several folks, actually this is something I think we've been doing now, goodness, for about 7 years in different clinical trials. It's yet to make it into clinical practice, but there are now commercial companies that are able to monitor cell-free DNA, and in the large cell lymphoma trials, it looks very predictive. In fact, in most patients, they could predict relapse before you could pick it up on imaging studies.
Yeah. And it turned negative pretty quickly.
Yes, and the other big thing, as you mentioned, is that not only could you actually predict early relapses, but you can hopefully determine who could be cured. So in patients that have negative PET, we know that about 30% of those patients will still relapse even with a negative PET. So it'd be ideal to be able to look at cell-free DNA in those negative PET scans and determine who would potentially need, for example, consolidation with a transplant.
So we talked about treatment. We talked about response on treatment. One of the questions that comes in lymphoma is maintenance therapy. And because there's still some patients who relapse, so Dr. Chavez, what do you think there's a role for maintenance therapy in large cell lymphoma?
Yeah, there has been several trials, looking at maintenance therapy based on experience in the benefit of maintenance therapy in follicular lymphoma and mantle cell lymphoma. So, investigators thought that could be also applicable in diffuse large cell lymphoma. Unfortunately, there is no data so far that improves the survival. There is data with, following CHOP-based therapy in older patients with lenalidomide, even though there was a progression-free survival benefit, not really overall survival benefit. So we have to be kind of very careful, doing maintenance therapy when there is no a strong data behind, because it adds toxicity, it may add cost to the patient and no real benefit. So at this time, I wouldn't recommend maintenance therapy, post-frontline therapy for diffuse large cell lymphoma.
The only maintenance benefit was actually the original ECOG study when they had CHOP versus R-CHOP. The patient who had not received the R-CHOP had a benefit for the maintenance, but that was expected.
But they did not receive the R-CHOP.
That was expected, yes. There's some discussion that in the, not gender bias, but sex differences of kinetics of rituximab, where the studies in France, they had a study when in child 13 or something, forgot, but that look at maintenance and then in male that showed maybe some benefit.